We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we've got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
Very unusual. One is at infancy and one is at adolescence. So 2 extremes of age group presenting with hypercalcemia. So this 4-month-old baby came with the complaints of failure to thrive. There was often on episodes of fever which the mother was complaining, which were measured and documented. There was also history of lethargy and feeding difficulty, which the child was complaining, and there was increase in the frequency of micturition and crying during those micturition episodes. On the antenatal and natal history, he was a full-term vaginal delivery. Birth weight was towards higher side, to a G3, P3 mother with no other history. There was history of perinatal asphyxia, for which the child needed an ICU admission for 4 days. However, he did not need any ventilatory support or any other major treatment on that part. There was no family history of hypercalcemia, renal calcification, and parathyroid surgery. There was no history of exogenous vitamin D or vitamin A, lithium, thiazide, and retinoic acid administration in this child. So with this kind of a picture, with these complaints, we had the possibilities of sepsis, UTI. Being in a medical college, we kept these possibilities before the investigations came in. And there was also a possibility of electrolyte abnormalities, hypercalcemia, neonatal diabetes, and rare possibility of immunodeficiency. So this was the patient. So there was generalized wasting, stunting. There was some syndromic phases in the form of triangular phases and retrognathia. However, there was no phenotypic picture of Williams syndrome. On the back examination, there were firm nodules on the back, which the mother did not notice, but on asking her, it had been present since day 4 of life, once he was discharged from the NICU. So there was wasting, stunting, microcephaly, and in the anthropometric examination. On further workup, the sepsis screen was normal, the blood glucose was normal, the CSF was normal, the serum calcium was very high, 15.07 total with the INA of 9.52. Serum phosphorus was towards higher side, which tells us that it was due to vitamin D related and not PTH related cause. ALP was normal for this age and kidney functions were normal. On further workup for hypercalcemia, the PTH was in the normal range. 25 hydroxy vitamin D was also normal, and 125 hydroxy vitamin D was towards higher side. The spot urinary calcium and creatinine ratio was higher, to the tune of 2 milligram per milligram, and USG KUB was done, which showed nephrocalcinosis in this child. So with this picture of high calcium with high phosphorus and normal PTH, we will be thinking on the lines of vitamin D related causes, which can be in the form of vitamin D excess, which may be due to exogenous, or 24 hydroxylase deficiency, which presents as a idiopathic hypercalcemia of infancy, or syndromic, where Williams is a possibility. Another possibility will be 1-alpha hydroxylase excess due to fat necrosis, sarcoidosis, or tuberculosis. And the least possibility was hypophosphatasia, because ALP was normal in this child. So I'll quickly run through this algorithm of hypercalcemia. Because the PTH was low, we did the 25 hydroxy, which was normal. So we did the calcitriol, which was towards higher sides. So now our possibilities are fat necrosis, tuberculosis, sarcoidosis. So on general examination, there were no clinical pointers towards tuberculosis. Sarcoidosis does not have a presentation at this age. So we are left with fat necrosis. And if we go back, we have a positive perinatal asphyxia history, and general examination showed those firm nodules. So it is definitely a case of fat necrosis. So we treated the child with normal saline bolus, followed by double hydration along with IV furosemide, and prednisolone was started at the dose of 2 milligram per kg per day, which was continued for 6 weeks. And gradually the serum calcium levels have come normal at 6 weeks, and we stopped the prednisolone at 6 weeks. And the child is doing well and is gaining weight. The developmental delay part is still persisting, probably due to the asphyxia component. So this was the first case. Now proceeding to the second case, that was a 14.5-year adolescent who came with the history of 5 years history of loss of appetite, and he was also presenting as failure to thrive. The father was saying whatever he eats, he does not gain weight, and there was short stature. There were chest deformities since 5 years of age, and localized swelling in the neck since 1.5 years, and genuvalgum since very recent 5 months onset. There was no history of fractures, polyuria, respiratory difficulty pointing towards no acidosis, no constipation, no encephalopathy, and there is no family history of hypercalcemia here too. So this is how the child looked, with severe chest deformities, and the genuvalgum is quite evident, and there was a localized thyroid swelling which was cystic on palpation. And there were no marphenoid features, no bumpy lips, which was seen in this child. So this was the anthropometric, where the child was having wasting with stunting, but the weight age was more affected, and the X-ray showed sarcopenia and erosions and scalloping like features due to low phosphorus. So the clinical possibilities with any adolescents presenting with skeletal changes and failure to thrive here would be hypophosphatemic rickets or distal RTA, or hyperparathyroidism, which may mimic rickets due to low phosphorus. So we worked on those lines. The counts were normal. There was mild anemia present. LFT was normal. Alkaline phosphatase was very high. And serum calcium was very high in this, to the tune of 19.5 milligram per deciliters. And ionic was also high. The serum phosphorus, as seen, is very low, pointing towards a PTH-related causes and not due to vitamin D. Kidney functions were normal. So for the further work for hypercalcemia, the serum PTH was very, very high. 25-hydroxy was towards higher side also. Probably this child would have received vitamin D in the periphery due to the skeletal changes. The spot urinary calcium creatinine was high, and USG KUB in this child did not show any nephrocalcinosis. The BMD was low, less than -2 standard deviation, and USG thyroid showed right thyroiditis with cystic nodule. FNAC showed Bethesda category 3A, atypia of unknown significance, and thyroid functions, prolactin levels were all normal in this child. So at present, he did not show any features of MEN1 and MEN2. So the clinical possibilities with hypercalcemia and hypophosphatemia with high PTH are only few. It is hyperparathyroidism or calcium sensing receptor defects, because calcium sensing receptor defect does not have skeletal changes, and if it is severe presence in the neonatal age group, we were concentrating on the hyperparathyroidism part. And usually in the adolescents, it is like a multifocal disease. So he's still awaiting MIBI scan, but it is not a necessity in this child. So we treated the child with normal saline bolus, followed by double hydration. IV zoledronic acid was also needed. And we put the child on oral cinacalcet, and gradually the serum calcium levels were coming down, and it could come down only on day 7. Still, the child is awaiting for his surgery, and he is on oral double hydration and cinacalcet and is doing better. Thank you. So we already know the approach to hypercalcemia. So this was high PTH and urinary calcium was high. So we are thinking about hyperparathyroidism. So the key message I would like to say with these two cases is that there should be a high index of suspicion of hypercalcemia in any neonate which presents with failure to thrive and non-specific complaints. Thorough clinical history examination and complete biochemical evaluation is essential. Subcutaneous fat necrosis should always be seen in the setting of perinatal asphyxia. Hyperparathyroidism can mimic rickets and should be kept as a possibility. So with that, I end this. Thank you.
Nice presentation, Dr. Arpita. Is there any questions? Yeah, please, Dr. Samana.
Very well presented, Dr. Arpita. Just wanted to ask that subcutaneous necrosis, often sometimes we see in a baby, but they're not often associated with hypercalcemia in all the cases. So is there a...
This was the first case I saw with subcutaneous fat necrosis with hypercalcemia.
Yes. So basically, subcutaneous necrosis, you will have more expression of 1-alpha hydroxylase. Now, how much is expressed? How much is the granulomatous tissue? So it's not that every subcutaneous necrosis will develop hypercalcemia. The more message, I think, very well put by Dr. Arpita was that phosphorus is the most important investigation in the setting of hypercalcemia. If your phosphorus level is high, that means it's basically a PTH independent / a vitamin D dependent cause. If the phosphorus is low, it's a PTH dependent cause. I think that will be there. So you need to worry about getting a calcium done in subcutaneous fat necrosis, but not all will develop hypercalcemia.
And how long will the nodules remain, sir?
Nodules may remain for some time because they're dead tissue. So they will remain for some time, but the active granulomatous tissue may go off in some time. So steroid therapy is somewhere around 2 to 8 weeks, depending upon the clinical scenario.
And the vitamin D supplementation has to be withheld during...
Absolutely. So because then all your vitamin D will be converted into calcitriol.
And then reintroduce calcium. Thank you.
I think the second important point was with regards to the hyperparathyroidism. Most children, and in fact, people who are below 18 and 30 years of age, they have a multifocal disease. So I think we were discussing that the scan was not done in this case. Scan is actually not going to help you out. Ultimately, it's a multifocal disease. You might have to remove nearly the whole of parathyroid. So we don't get much benefit of scan below 30 years of age. I think that will be an important thing to remember. And men association, again, will be very less likely in this case, but we have to be a bit aware about that scenario. It's usually in the second, third decade that you start having those scenarios.
Thank you.
What are the chances of recurrence of fat necrosis?
Of fat necrosis, usually they don't recur. It's just that you stop the treatment early, they may come back. But otherwise, the necrosis, they will gradually die down its own course.